I think we're good to start.
Okay, we will get started. Good morning, good afternoon to all the attendees, wherever you are. Thank you for joining, and thank you to the Rare Disorders Committee and the HS for organizing. We are going to have the Rare Disorders webinar today, just some housekeeping items. So everyone will be muted apart from the speakers. Please submit any comments into the chat. And then if you submit some questions into the Q&A, we'll do our best to have some discussion to address some questions at the end. And I will, without further ado, we'll start with Dr. Askaya from the NIH NCI, who's going to present her study about indeterminate cell histiocytosis.
Hello everyone, I'm Neval Özkaya, and I hope you can see my screen.
Yes, we can see it.
Thank you. So thanks very much for the invitation. And today I would like to present our study entitled Indeterminate Dendritic Cell Histiocytosis is distinct from Langerhans cell histiocytosis and often associated with other hematopoietic neoplasms. And with this, I would like to start introducing my colleagues first, who contributed this study. So this study was a collaboration between the NIH and French Histiocytoses Registry. And people highlighted in red color were directly involved in this study, namely from NIH, myself, and Dr. Elaine Jeffy, and from France, Dr. Jean-François Emile and Sarah Benizri. And I would like to thank also other members of the Laboratory of Pathology of the NIH, as well as other members of the French Histiocytoses Registry. I have nothing to disclose. So the term histiocyte has been variously used to describe both tissue macrophages and dendritic cells. And histiocytosis means abnormal proliferation of a histiocyte. And for this talk, when I say histiocytosis, I'll be implying histiocytic neoplasms. So histiocytes accumulate in various tissues and come in a variety of flavors. And historically, histiocytoses have been classified as Langerhans cell histiocytosis and non-Langerhans cell histiocytosis. The underlying reason for this distinction was that initially Langerhans cell histiocytosis, LCH, was thought to be the sole dendritic cell disorder. And regarding non-LCH category, initially it was thought that all of the other histiocytosis subtypes were actually macrophage disorders. In other words, people were trying to come up with a cell of origin-based classification system with available information at that time. And all of these were based on presumed cell of origin, of course. But subsequently, other disorders with presumed dendritic cell origin have been described, such as indeterminate dendritic cell histiocytosis or interdigitating dendritic cell sarcoma. And with this understanding, because of this reason, for the past several years, WHO and ICC classified histiocytosis based on two different situations. First, it can be based on presumed cell of origin, if there is any characteristic phenotype implying a cell of origin. I think LCH probably can be a good example for that, for this scenario. It has Birbeck granules or Langerhans expression, implying that it has identical phenotype with the normal Langerhans cells. Therefore, we named it based on possible normal tissue counterpart. But some diseases or some cases do not have such a characteristic phenotype. Instead, they are distinct clinicopathologic entities. For example, Erdem-Chester disease can be a good example for that. It really has a characteristic tissue distribution, characteristic clinical and radiological features. Therefore, some diseases were named based on clinicopathologic presentation. And this is the list of histiocytic neoplasms from ICC and WHO. And for today's talk, we will focus on indeterminate dendritic cell histiocytosis moving forward. So I would like to show you an example, a representative case to give you an idea what was my initial experience with this disease and why I picked this topic to study it further. So this is a lymph node excision from an 89-year-old male patient who had an enlarging left posterior scalp lesion, and he underwent an excision, which was initially called as Langerhans cell histiocytosis at the outside institution. And for some reason, this case was sent to us for a second opinion. And as a note, this patient also had a recent clinical diagnosis of CMML, chronic myelomonocytic leukemia, as per the clinical notes. So as you see here, on the H&E section, the lymph node was entirely replaced by an atypical histiocytic infiltrate, and some of them had the grooved nuclei as similar to those seen in Langerhans cell histiocytosis. However, unlike LCH, there is really no admixed eosinophils that you would expect to see in LCH, and there were also some small foci of necrosis throughout the section. And by immunochemistry, these cells were diffusely positive for S100 protein and CD1A, but were completely negative for Langerin. And we diagnosed this case as indeterminate dendritic cell histiocytosis according to WHO 2017 at that time, due to the presence of CD1A and S100 protein expression, as well as Langerhans cell-like LCH-like cytological features, but absence of Langerin, which is a surrogate marker for Birbeck granules. Then we performed targeted sequencing studies in our lab. It is a targeted DNA and RNA panel. So we found pathogenic ASXL1 and U2AF1 mutations, which are generally myeloid neoplasm-associated alterations. And also there was an NTRK1 kinase fusion by RNA sequencing. Then we performed a pan-TRK immunochemistry, which is a useful stain for the identification of NTRK protein overexpression caused by gene fusions. So it is especially helpful to prove that this fusion is actually coming from the histiocytes. And as you see in the picture, that the histiocytes are staining positive. Then the clinician called me to discuss this case further, since he probably didn't really understand what the diagnosis. It's a rare diagnosis. Anyway, I tried to explain, and he asked me that why we don't call this case as Langerhans cell histiocytosis, because this was the first diagnosis, basically. So I explained that Langerin stain is negative and we cannot call it LCH. And he said that he asked me, is the absence of Langerin stain really clinically means anything? Then I said, I don't know, and I don't think anyone knows the answer. We don't know the clinical implications, really. But then after this conversation, I started to think by myself, there are a number of controversies. First, the patient is old, it's 89-year-old, and LCH is mostly known to be a pediatric or young adulthood disease. And second, there was underlying CMML history, chronic myelomonocytic leukemia history, which is not very common association in LCH. And then I forgot about this case for a while. However, over the next few months, I got two more indeterminate dendritic cell histiocytosis cases back to back, and both had history of underlying myeloid neoplasm. Then I literally started to think if there is a de novo indeterminate dendritic cell histiocytosis case, and I decided to do some literature search. So this is some historical background here. Indeterminate dendritic cell histiocytosis was first reported in 1985. Initially described in one patient with multiple cutaneous lesions, and it was histologically described as a histiocytic lesion. Cytologically looks like LCH, but doesn't contain Birbeck granules by electron microscopy. That's why it was called as indeterminate dendritic cell histiocytosis. And it is obviously a rare disease for sure, but also probably underdiagnosed disease, since the pathologist may not perform Langerin stain all the time during the histiocytosis workup. This was the case in our first index case. And they may stop just after the detection of CD1A expression and diagnose the case as LCH. Or sometimes pathologists tend to interpret a negative Langerin stain as a sign for immaturity, and again diagnose the case as LCH or even sometimes Langerhans cell sarcoma. And these classification approaches are not correct according to current guidelines or literature. And to my knowledge, That is by far the most comprehensive study done in indeterminate dendritic cell histiocytosis, describing 5 patients in 2008, just before molecular revolution started in histiocytosis. And as you see, as highlighted, one patient reportedly had concomitant follicular lymphoma, and another one presented with a systemic disease with multiple lymph nodes and splenomegaly and died quickly after the diagnosis. Since autopsy was not performed, it is not clear whether this patient had an associated malignancy or not. And in 2015, Stanford group found an ETV3-NCOA2 fusion in 3 out of 4 patients tested. So the initial reference case in this study was sent to Foundation 1 for NGS testing, which detected this fusion. Subsequently, they used a double fusion fish probe in order to screen some other cases. They also screened 11 cases of LCH by fish, which were all negative for this fusion. Therefore, they suggested that indeterminate dendritic cell histiocytosis is a distinct neoplastic category, and it is associated with a recurrent ETV3-NCOA2 fusion. But as you may remember, we found a different fusion involving NTRK1 gene in our case. So then I decided to work on this topic. So this is a collaborative study between NIH and Hôpital Ambroise Paré from France. We assembled our cases in order to make a comprehensive histopathologic and molecular genetic analysis on a large series of IDCH, indeterminate dendritic cell histiocytosis, to better understand its classification and pathogenesis. And our goals in this study to characterize the full spectrum of pathologic findings in indeterminate cell histiocytosis. I will try to go over some important data about histology, immunohistochemistry, and genetic findings. Second goal is to identify the clinical pathologic differences from the LCH, if there is any difference, and to identify the extent of association with other hematopoietic neoplasms. And our inclusion criteria were tissue biopsy demonstrating pathological signs of a neoplastic histiocytosis, expression of at least one histiocyte marker. It can be CD4, CD68, or CD163, doesn't have to be all together. CD1A expression in the majority of lesional cells, Langerhans expression limited to only small subset of the lesional cells, or ideally total absence. And S100 protein expression was not considered as an inclusion criterion due to controversial data in the literature. We just wanted to be more inclusive initially. So all cases were reviewed in online group meetings, in Zoom meetings, from NIH, myself and Dr. Elaine Jeffy, and from France, Dr. Sarah Benizli and Dr. Jean-François Emile joined all of these meetings. And basically all cases were decided based on consensus. So far, we evaluated 45 cases, and 38 were eligible for inclusion in this study. And 7 cases were excluded because a reactive histiocytic dendritic cell hyperplasia could not be completely ruled out. So here is shown that we have 38 patients, including 33 adults and 5 pediatric patients. The median age was 70, which is the first difference from LCH that I can tell, since LCH is mostly a pediatric disease or young adulthood disease. But we had 5 pediatric patients as well in this cohort. And we can see on the right-hand side, the breakdown of diagnostic subgroups. 21 patients had actually primary indeterminate dendritic cell histiocytosis, which means there was no additional hematopoietic malignancy other than histiocytosis in these patients. And 17 patients, which is about 45% of our cohort, had a secondary IDCH, which means they were associated with other hematopoietic malignancies. Most commonly, it was CMML, chronic myelomonocytic leukemia, AML, MDS-AML, and there were 5 patients associated with lymphoproliferative disorders. And the most common clinical presentation was skin rash without any other lesion in about 60% of the patients, and about 20% of the patients had actually multiple lymph node enlargement. And another thing to mention is that 7 patients had another subtype of histiocytosis, so-called mixed histiocytosis. So in terms of morphological findings, we really couldn't come up with a reliable cytological grading system to split the cases as low grade and high grade as we do in Langerhans cell histiocytosis and Langerhans cell sarcoma. The nuclear features of the lesional cells were resembling to the lesional cells of the LCH in almost all biopsies. However, unlike LCH, admixed eosinophils were rare to absent in most biopsies, and necrosis was present in 5 cases in which IDCH were associated with other hematopoietic malignancies, but not all malignancy-associated cases contain necrosis. In most of the skin biopsies, which was the most common site, biopsy site, the neoplastic cells revealed a diffuse dense infiltration within the superficial and deep dermis, and overlying epidermis was mostly unremarkable without epidermotropism. However, a few biopsies were revealing some unusual features, including perivascular periadnexal infiltration pattern, focal epidermal ulceration, or epidermal tropism were also noted. So immunohistochemical findings are shown here. For diagnostic purposes, one of the messages that I would like to highlight here is that many cases were actually negative for CD163 and negative for CD68 as well. So whenever you see a dense histiocytic infiltrate which are negative for CD163 and CD68, please do not forget to consider dendritic cell origin. And I actually really like to use CD4 in this context. I think it's one of the most sensitive histiocytic marker that covers both macrophages as well as dendritic cell lineages. However, it's not specific as and its use requires some caution. And as you see, all cases tested were positive for CD4 and CD1C. And CD1A immunostain showed strong membrane staining and was positive essentially in entire population of the neoplastic histiocytes in vast majority of the biopsies as part of the inclusion criterion. So the molecular findings are shown in this oncoprint. Every column in this graph represents a single patient. What you can see here is that high frequency of BRAF mutations, and it is mostly V600E. A couple of cases wasn't V600E, but mostly V600E. And KRAS mutations also were very common. There are also some cases with MEP2K1, other RAS isoforms, or NF1 mutations. We also identified a set of fusions involving BRAF, NTRK1, NCOA2, which was initially described, but we saw this fusion only in 2 cases, in 2 out of 38, and MLL fusion as well. We described 1 MLL fusion. And other important finding is that in addition to harboring well-characterized histiocytosis driving alterations, patients also carried concurrent mutations in genes which are commonly mutated in myeloid neoplasms, such as mutations in TET2, DNMT3A, ASXL1, etc. And presence of myeloid neoplasm associated mutations were independent from the presence of an overt myeloid malignancy, suggesting the presence of underlying clonal hematopoiesis. Cases associated with a follicular lymphoma harbored well-defined follicular lymphoma alterations, such as CREP-BP and TNF-RSF14 mutations, as well as BCL2 translocation, and didn't have any myeloid neoplasm-associated mutations or clonal hematopoiesis related mutations, suggesting suggesting a different evolution mechanism occurs in lymphoma-associated cases. Also, 7 patients, which is about 20% of our cohort, had concurrent or prior histiocytosis with non-ICH histology, including 3 patients with Erdheim-Chester disease, 1 patient, including 1 patient with mixed ECD-LCH, 3 patients with LCH, and 1 patient with Rosai-Dorfman disease, consistent with mixed histiocytosis. So obviously there is a common association and a possible relationship between indeterminate dendritic cell histiocytosis and Erdheim-Chester disease, as well as Langerhans cell histiocytosis, which we still don't understand well. But in mixed histiocytosis cases, IDCH appear to frequently contain a BRAF V600E mutation rather than KRAS or other mutations. So the Langerhans cell histiocytosis is a more common disease, as you know, and a better studied disease in terms of clinical pathologic and molecular features in the literature. So we aimed to compare the results of our IDCH patients with published literature in LCH to see how similar they are or how different they are. As I mentioned previously, we uncovered a striking association of concomitant hematopoietic neoplasm in our patients. It's about 45% of the cases. And this is the list of, just as a reminder, this is the list of our cases with associated hematopoietic neoplasm. But we know that there is no such a striking association reported in LCH. For example, on the right-hand side, you can see that I cited an ASH abstract from Dr. Goyal. Dr. Goyal was a co-author in this study, actually. So this was a recent ASH abstract. They included almost 1,400 cases with LCH from the SEER databases, and they found that only 20 patients, which is 1.4% of their cohort, developed a second malignancy, which are not necessarily hematopoietic malignancy, by the way. So obviously, in terms of concomitant hematopoietic neoplasm, the indeterminate dendritic cell histiocytosis and LCH seem to be very different diseases. So for the comparison of mutational profiles, we picked this recent study. Dr. Durham was the lead author for this study. So this is a pretty large cohort published in Nature Medicine recently. And they have done a comprehensive genomic analysis for the LCH. So molecular profile of IDCH in our cohort showed significant enrichment in KRAS and NRAS mutations, which are extremely rare in LCH. Although here actually you can see the IDCH cases, indeterminate dendritic cell histiocytosis cases, are shown in blue, and LCH cases are shown in orange, just to orient. Although both diseases have frequent BRAF V600E mutations, indeterminate dendritic cell histiocytosis appears to have concurrent mutations in myeloid neoplasm-associated genes, such as TET2, DNMT3A, ASXL1, EZH2, unlike LCH. It wasn't very common in LCH. And regarding comparison of the immunohistochemical features, we noted that most of the cases were actually negative for CSF1R expression in indeterminate dendritic cell histiocytosis, shown on the left-hand side. So this was from our study, from our cohort. It's about 83% of the cases actually were negative for CSF1R expression in the tissue biopsies. However, a recent study actually reported a universal CSF1R expression in LCH, in Langerhans cell histiocytosis, that I cited on the right-hand side for comparison. So in other words, IDCH and LCH seem to use different cell surface receptor, since there is a significant difference in CSF1R expression. As you know, this is the other name is MCSF receptor for CSF1R. So this is one of our cases as an example for the CSF1R expression. This patient was one of the primary IDCH cases and was not associated with any hematopoietic neoplasm. NGS studies detected a pathogenic TET2 and KRAS mutations. TET2 was suggesting underlying clonal hematopoiesis. And as you see on the left-hand side, CSF1R stain is completely negative. In contrast, cyclin D1 is strongly positive on the right-hand side in the lesional cells, despite the absence of CSF1R. It is likely due to KRAS mutation, which is causing MAP kinase pathway activation. So in conclusion, IDCH appears to be clinically and genetically heterogeneous disease. It has different immunohistochemical, mutational, and clinical features from the LCH. ETV3 and COA2 fusions are rarely present in IDCH, and it's obviously not a hallmark of this disease, like genetic hallmark. And most of the cases harbor myeloid neoplasm-associated mutations in the background of well-known histiocytosis drivers, even in the absence of an overt myeloid neoplasm. And it is highly associated with other hematopoietic neoplasms. It can be myeloid, lymphoid, and other histiocytic neoplasms. And thank you very much. I hope I convinced you that it's not just about a negative Langerhans stain.
Thank you, Dr. Eskaya. We could take some time for discussion for this. I see one one question from Core. I guess this is a question for Jean-Francois. Core is asking whether, I guess, his patient or the registry patient was included in this series.
Oh, no, we haven't. At the moment, I haven't seen any case like this, Hashimoto-Pritzker at the moment.
Okay.
We have more adults, indeed.
We have a question also. I guess it's more as a comment from Arturo Bonometti saying very interesting data. Actually, we predicted these results into abstract posters of the Histiocyte Society. They're currently in reviewing and they've provided links. So there may be opportunity to compare the data between the two studies, between peds and adult. Jorge has a question, I think.
Jorge, did you want to ask something?
He needs to be unmuted, probably. Jorge, I think you're muted.
One question, in the patients without neoplasia or without any hematologic problems at diagnosis, do you perform a bone marrow? What do you find as a morphology problem? The question is because maybe there are already myelodysplastic change at diagnosis.
So yeah, thank you for the question. So most of our cases, actually, the underlying hematopoietic neoplasm, either it was concomitant, like at the same time patient got the diagnosis, or hematopoietic neoplasm, as you mentioned, preceded. Basically, it's like there was initial diagnosis. So I think there are two important points here. First of all, just to be aware, the awareness is important. For example, if the patient has underlying CMML and now presenting with histiocytosis, I think like indeterminate dentic cell histiocytosis, it's important to be aware from the as a pathologist, they will be probably related. It's just some sort of progression of the underlying hematopoietic neoplasm. And second thing is, if there is no history, basically, we are at least trying to be careful with just to make sure we review the CBC, complete blood count, or if there is any clinical scenario that didn't make sense, if it looks more, I don't know, the disease extent, just to make sure we are trying to see the disease extent. And if the all clinical scenario doesn't make sense, we prefer to talk to a clinician to evaluate the patient better, basically. So that was the point. I'm not trying to say we should just go ahead and do staging marrow for every single patient. This wasn't my point.
I think Osama has a question.
Yes, thank you for this interesting presentation. I know this was a clinical pathological study, but did you collect data about treatment and outcome of these patients, especially the non-associated with neoplasia?
So that part is still ongoing, actually. You are right. I think it will be important. Unfortunately, most of the cases were consultation cases. So I'm still trying to come up with a reliable, at least maybe for the subset of the patients. But it seems like if they are not related to underlying neoplasm malignancy, they seem like a very indolent. They seem like a indolent diseases, actually. But if there is underlying malignancy, obviously depends on the malignancy subtype. It may go bad.
Thank you.
Karen?
Yeah, hi, Naval.
Hello.
Really great study. I was wondering, I think in one of your early slides, you mentioned the criteria for inclusion, and you mentioned that the Lundgren stain was less than 20% positive in less than 20% of cells.
Mm-hmm.
In the cases that did have some low-level Lundgren expression, did those cases seem to be different than the cases that were completely negative? Did they have a more likely association with an underlying myeloid neoplasm or certain mutations?
So thank you very much for the question. And actually, I was expecting to get this question. It was a big discussion during our meetings, like between us. So basically, it was first of all, it was a natural cutoff. We didn't just put a 20% cutoff, but it was the case with the highest Langerhans expression just naturally reached up to the 20%. And then we said, okay, we should just include those cases because we are not clear if they should be classified as LCH or indeterminate dendritic cell histiocytosis. And we just wanted to be inclusive about that. And it seemed like if the cases have more Langerhans expression, they may have more BRAF mutations or MET2K1 mutations rather than KRAS mutations, for example, because this was also KRAS mutations were also pretty common. So it seemed like it's more like within the spectrum of mixed histiocytosis, maybe with the higher Langerhans expression. But still, basically, I think we will try to work on those cases more just to make sure how we should classify them, basically.
Thank you.
Thank you.
Okay, thank you so much. If there's no other questions or comments, we'll move on to Dr. Durham's presentation. Ben, please go ahead.
Okay, I'd like to thank the organizers for inviting us for our presentation entitled RAF Independent MEK1 Mutations Drive Histiocytic Neoplasms in Vivo and are sensitive to single agent ERK inhibition in patients. So you've already heard a nice discussion about histiocytoses and the classifications from Naval just recently, but just to reiterate, these are disorders characterized by accumulation of histiocytes, which are macrophage dendritic cells, or monocyte-derived cells, which is monocyte-derived dendritic cells, which are CD11b positive dendritic cells in various tissues with histiocytes that were historically very poorly characterized and had a very obscure pathophysiology before. A lot of us started working on this about 10 years ago. And these are largely classified, of course, as you already heard, into Langerhans cell histiocytosis and into non-Langerhans cell histiocytoses, which included Erdem-Chester disease, juvenile and adult xanthogranulomatoses, Rosai-Dorfman disease, and of course, indeterminate cell histiocytosis or indeterminate dendritic cell histiocytosis, as Neville just discussed. And the big distinction at that time, of course, that has been used over the years has been immunohistochemistry and pathology, such as do the cells express CD1A and Langerhans, or do they do not? And of course, indeterminate cell histiocytosis does express CD1A, but doesn't express Langerhans in most cases, while LCH does express Langerhans, also known as CD207. And these are systemic diseases that we all have seen involve multiple tissues. They can involve the skin, they can involve the bone, they can involve the lung, the central nervous system. And when they're systemic, and that goes for both LCH as well as the non-LCH neoplasms. And of course, Erdem-Chester has more classic features involving the technetium 99 scanning involving the long bones of the skeletal system. And of course, the non-LCH neoplasms, Erdem-Chester typically affect more the appendicular skeleton, while LCH affects more the axioskeletal system. But then until recently, and of course, for years, as we mentioned, the pathophysiology has been very obscure. And for years, we thought these were potentially immunological disorders, and didn't really know they were neoplastic conditions. But then work that came out of our laboratory, as well as others, including Carl Allen's laboratory, Kid McLean and Baylor College of Medicine, Barrett Rollins' laboratory, Ashish Kumar's laboratory, we found that there are multiple mutations involving the MAP kinase signaling cascade, as well as the PI3 AKT mTOR signaling cascades in both LCH and non-LCH neoplasms. And BRF was potentially seen very heavily within Erdem-Chester disease within non-LCH neoplasms, and of course in Langerhans cell histiocytosis. The second most frequent mutation was MAP2K1, and in both LCH and non-LCH neoplasms. And then you see a number of receptor tyrosine kinase mutations and fusions in the non-LCH neoplasms, with fewer LTK mutations seen in LCH. So we were established over the past 10 years that these are definitively neoplastic conditions and not just immunological phenomena. So with that, with the molecular age of histiocytosis upon us, we were able to move into molecular therapeutics for these disorders, which had no FDA-approved therapy. So our group and others studied vemurafenib and BRF-V600E mutant histiocytoses, and our group led by Eli Diamond and David Hyman found beautiful efficacy of vemurafenib for BRF-V600 mutant histiocytoses. And this is also confirmed by studies from the French group led by Julien Haroche and Jean Donadieu. And all of this led to the FDA approval of vemurafenib for treating BRF-V600 mutated Erdem Chester disease in 2017, providing the first FDA-approved therapy for histiocytoses. And particularly that was for Erdem Chester disease in this case, and not LCH, which is still being studied more extensively. And then cobimetinib for histiocytoses, we started studying this led by Eli Diamond and a group, and we did the bench work in Omar Abdul-Wahab's lab, looking at cobimetinib across histiocytosis genotypes. And we saw great efficacy of allosteric MEK inhibitor cobimetinib. And then this just recently was approved by the FDA just last year on November 2nd of 2022 for BRF-V600 wild-type histiocytic neoplasms. So now we have 2 FDA-approved therapies for the histiocytic disorders. However, all of our patients within our cobimetinib trial didn't respond beautifully to cobimetinib. We had some that developed refractory or resistant disease, and we looked more at these patients, and they happened to have MEK1E1203 deletions, which is encoded by MAP2K1, and these have been recently covered by work at a Neil Rosen laboratory. That these are RAF-independent MEK mutations or class 3 MEK mutations that are resistant to allosteric MEK inhibitors such as trametinib and cobimetinib. And when we looked at our cohort, our particular cohort, and across the more recent sequencing cohort, we had about 300 or more so of patients recently. We see that the most frequent MAP2K1 mutation in our patients was the MEK1E1203 deletion, which being this RAF-independent or biochemical class 3 MEK1 mutation, that in vivo or in vitro has been seen to be resistant. So basically, the cell lines have been resistant to trametinib and cobimetinib, which are allosteric MEK inhibitors, which again, cobimetinib again being FDA approved now for BRF-V600 wild-type histiocytoses, but these patients largely don't respond to them very well. So there's definitely a need for new therapies in these patients. So this led us, this as well as the discovery of MEK1 mutations being the second most frequently mutated, second most frequent group of mutations in histiocytoses, led our group to look at MEK1 mutations. Can they actually drive histiocytosis development in vivo? So basically, are they driving in mouse models? What disease phenotypes emerge with MEK mutations are expressed at different stages of hematopoietic development. So if we express them under the early stages of hematopoietic development, such as MX1-CRE or VAV1-CRE, so in the hematopoietic stem cell multipotent progenitor levels of hematopoiesis, or at the more committed monocyte dendritic cell progenitor level, which is under CD11C-CRE promoters. And then what is the best therapeutic approach for MEK1E1203 mutated histiocytoses or other class 3 MEK1 mutations, which there are several, and we do have other class 3 MEK1 mutations patients in our cohort that are not responding beautifully, aren't responding that well to cobimetinib at this point. So we developed a conditional knock-in mouse model involving knocking in a mutation in exon 3 that encoded in the autogenous locus of MAP2K1 within the mouse genome to encode E1203 deletion. We crossed these with a number of promoter mice, MX1-CRE, VAV1-CRE, and CD11C-CRE promoter mice. And we, of course, we have CRE-negative MAP2K1 mutant control mice, and then we have we have MX1-CRE or VAV1-CRE, CD11C-CRE positive MEK1 mutant mice. And by next generation sequencing, we were able to confirm that the mutation was definitely present in the CRE positive MEK1 mutated mice, while the CRE negative mice were negative for the MEK1 mutation. So it was a conditional expression, basically, this presence only in CRE positive mice. So when looking at the death curves basically are the Kaplan-Meier curves of these mice. The CRE positive and negative controls did not develop any illness. They were fine. When they compared to their littermate controls that were either MX1 CRE or VAB1 CRE or C11C CRE positive, we saw that they had decreased survival in the MX1 CRE MEC1 mutant mice by 5 to 6 weeks of age. They were already developing a lethal myelomonocytic disorder that was overexpressing MAP2K1 in the bone marrow. So you could see by biochemical studies of bone marrow and spleen, we were also able to see overexpression of phospho-MEC and phospho-ERK, showing definite overexpression of the MAP kinase signaling cascade in the CRE positive MEC1 mutant mice compared to CRE negative controls. So we knew that the mutation by next generation sequencing is present in the CRE positive mice and also expressed within hematopoietic tissues. So we had conditional and we had specific expression for that CREs in hematopoietic tissue, which is why we wanted to study this mutation and how it affects hematopoiesis. So when looking at the mice, we see that the MX1 CRE MEC1 mutant mice are small compared to littermate controls. So they had failure to thrive. They have these are spleens, so splenomegaly. That was significant. They also had hepatomegaly. And then when looking at the peripheral blood counts, we see the white blood cell count was not really significantly different. Hemoglobin, there was significant anemia within the CRE positive MEC1 mutant mice compared to the CRE negative mice. And there's also thrombocytopenia. And then when looking at the white blood cell subsets, we were able to see with controls in mice, the most frequent circulating white blood cell, unlike in humans, in mice, it's a B lymphocyte. In humans, it's neutrophils. And in mice, we had B lymphocytes in the control mice were the most frequent subset of white blood cells with very few monocytes. But then when you look at the CRE positive mice, I go to MX1 CRE, VAB1 CRE, and C11C CRE positive mice, we see a suppression of the B lymphocytes and of lymphocytes in general. We see a major expansion of the monocyte compartment and also suppression of the eosinophil compartment and other type of granulocytes. This was further confirmed by flow cytometry on blood, bone marrow, spleen, and liver. And this is an example of bone marrow flow showing a major suppression of B220 or B lymphocytes compared to control mice. So the B cells are definitely suppressed. The T cells are not significantly depressed. And when looking at the spleen, when staining for B220 with immunohistochemistry, the spleen, basically the white pulp of the spleen was beautiful in the control mice. It's basically essentially negative for B220. So there's a major suppression of B lymphopoiesis in our CRE positive mice. And we further looked at monocyte and dendritic cell subsets. So we looked at monocyte subsets. So we looked at the classical monocytes, which were in mice are Ly6C positive and in CD115 positive. And these were expanded compared to control mice. We also looked at the non-classical monocytes, which are MCXCR31 positive and CD115 positive. And we also looked at the macrophages. Again, this is a bone marrow spleen. We also looked at liver, but I'm just showing examples here where we had expansion of the monocytes of macrophages. The macrophages, we saw more of expansion, of course, in spleen and liver compared to littermate controls. And then when looking at the classical dendritic cells, there's classical dendritic cell type 1, which are CD24 positive dendritic cells in mice. These are within lymphoid organs, such as bone marrow and spleen. And then there's classical dendritic cell type 2s, or CD11B positive dendritic cells, and these were expanded in the bone marrow and the spleen of our CRE positive MEC1 mutant mice compared to our littermate controls. The littermate controls are in red, and the experimental mice or CRE positive mice are in blue. And then looking histologically, the control mice, they had EBA1 is a monocyte macrophage specific stain, and in mice for macrophages as well as monocyte derived tissue, CD11B positive dendritic cells. And they didn't have overexpression of phospho-ERK. They had limited expansion of EBA1 positive cells within the bone marrow. Within the controls, when you look at the CRE positive mice, especially MX1 CRE, there's a major expansion of infiltration of EBA1 positive monocyte macrophages subsets, as well as CD11B positive dendritic cells. They're also overexpressing phospho-ERK1/2 by immunohistochemistry. We see this in VAB1 CRE as well. These both express at early stages of hematopoietic development. And we also see this in CD11C CRE, even though there's not as much of an overexpression of phospho-ERK. And we also saw this as spleen, and then where this is an example of the liver, where the control, you typically have the nice, scattered Kupffer cells, which are macrophage derived, or tissue derived macrophages in the liver. And there's not a major overexpression of phospho-ERK, but when you look at the Cre-positive mice, MX1 Cre, there's a major collection of these EB1 positive cells forming even small granulomata. They're overexpressing phospho-ERK1/2. VAV1 is the only Cre. They're not as overexpressing phospho-ERK1/2 as much as MX1 Cre, but we do see major infiltration in the sinusoids of the liver and developing a granulomata throughout the liver parenchyma. And then looking also at the skin of the mice, the Cre-positive mice developed skin lesions, those xanthographic skin lesions. So control mice within the dermis were fairly clear of major inflammatory infiltrates, but you have major infiltrates of basically macrophages, monocytes, CLMV positive dendritic cells that are EB1 positive within the dermis of the MX1 Cre positive MAP21 mutant mice. They overexpress phospho-ERK1/2, and all this is negative in the Cre and the Cre negative MEK1 mutant mice are the control mice. And these are also serially transplantable, which is a major thing in mouse biology where you see can a disease be transplanted. So we took bone marrow from control mice and transplanted it into lethally irradiated CD45.1 mice, and then also bone marrow from MX1 Cre MEK1 mutant mice. And those also, they developed, the serially transplanted mice developed a lethal myelomonocytic disorder, similar to what was seen in the primary mice with major expansion of the spleen and the liver compared to control mice. And the flow cytometry is very similar, but for lack of time, I'm not showing all of that at this point to the primary mice. And so we also saw major infiltration of EB1 positive cells within the bone marrow, spleen, and liver of the MX1 Cre MEK1 mutant transplanted mice compared to the Cre negative control mice that received Cre negative MEK1 mutant bone marrow, showing very similar features to what we saw with this histiocytosis like myelomonocytic neoplasm developing in the MX1 Cre MEK1 mutant transplanted mice compared to the Cre negative mice, just like we were seeing the primary MX1 Cre MEK1 mutant mice. So we have very clear, at this point, we're getting a fairly clear mouse model that MAP2K1 can develop a histiocytosis like neoplasm, and when expressed at early stages of hematopoietic development, either the hematopoietic stem progenitor levels or even at the committed monocyte dendritic cell progenitor level under C11C Cre. And then, so we have a potential model we can use for studying new therapies for these patients that with this mutation that's actually a class 3 MEK1 mutant that doesn't respond very well to cobimetinib in our patients cohort. So just moving back to the patient cohort to emphasize the findings we saw clinically and the need for doing kind of preclinical trials in our mouse models to find new therapies, is many of our patients, several of the patients in our trial that were MEK1 E1203 mutant, still had xanthogranuloma in the xanthelasmas in the skin. They also had involvement of the lung, and this still continued to even worse progress even while on the allosteric MEK inhibitors such as cobimetinib. This is an example of these patients. And then several of our patients had been on multiple therapies, including MEK inhibition in blue, and there we see a red arrowhead that's actually progression of disease. And many of these had progression even on the MEK inhibitor, and some patients were very, very ill. So we had to get compassionate single agent use for these patients to try something else when the MEK inhibitor stopped working in these patients or never worked in the first place. So we used ulixertinib, which is an ERK1/2 inhibitor, which you'll see more in this kind of aqua color. And some of the patients had progression of MEK1 mutations. So the few anecdotal cases we saw had nice responses to this disease, to this inhibitor. And then here's some examples clinically and radiographically where patients pre-ulixertinib, the ERK1/2 inhibitor, had extensive disease, and they responded beautifully to ulixertinib. And then some that we treated naive that had, and here's the LCH patient that had MAP2K1 E1203 deletion involving the central nervous system as well as the perirenal regions, and they responded very well to ulixertinib while on ulixertinib, while they had not been responding or had been progressing on allosteric MEK inhibitors such as cobimetinib. So ulixertinib has, at least in these few anecdotal cases, seems to have very promising efficacy in class 3 MEK1 mutant patients such as MAP2K1 E1203. So in conclusion, MEK1 E1203 deletion drives a lethal myelomonocytic disorder reminiscent of human histiocytosis in vivo. This can occur when it's expressed under MX1 Cre, VAV1 Cre, or C11C Cre. So at the early stages of hematopoietic development, or at the monocyte dendritic cell committed progenitor level. It's cellularly transplantable. Expressed MEK1 mutation at the early stage of medical development seems to result in a more severe disease. They died much earlier than the C11C Cree mice started dying. And this leads to a suppression of B lymphopoiesis and expansion of the myelomonocytic compartment, with a particular expansion of the monocyte macrophage compartment and monocyte-derived dendritic cells such as CD11B positive dendritic cells in the bone marrow, spleen, liver, and skin, which are all major organs involved in human histiocytoses. So the MEK1 EO1/2/3 conditional knock-in mouse seems to be a histiocytosis mouse model now. It seems could be potentially a promising preclinical model to test single agent or combinatorial agent therapeutics for histiocytic neoplasms, such as in these patients that don't respond well to allosteric MEK inhibitors. And at least in a few of the anecdotal cases that we have, Histiocyte with ERK1/2 inhibitor seems to show promising efficacy as a monotherapy in class 3 MEK1 mutant histiocytosis patients. And hopefully preclinical trials in the mouse models and some of these anecdotal data from our patients will build a foundation for future clinical trials beyond single agent MEK inhibitors for class 3 MEK1 mutant patients, such as those harboring MEK1 E1/2/3 deletions. So I could thank you for your attention. I think my research mentor, Omar Abdul Wahab, and our clinical colleague and leader of all clinical trials, Eli Diamond, at our institution, as well as many other members of the laboratory, including one of my awesome technologists, Michael Singer, does a lot of work, necropsy work in the lab. And of course, my co-mentor, Neil Rosen, who helps a lot with the biochemistry, and many of our other collaborators, both domestic, at St. Children's Hospital, Jim McCarthy, who helps us with the studies over time with the sequencing of patients, and the St. Jude's as well, and also our clinical colleagues who we've worked with for many years closely, Jean-Francois Emile, Julian Hiroche, Jean Donadieu, and in CERN in Paris. And of course, our funding sources for which we can't do any of this work. And I'll take any questions at this time.
Thank you, Ben, for that wonderful presentation. We have one question from Astrid, which is whether you're able to trace this mutation in lymphoid cells.
We have not. We do not. We don't find the mutation in lymphoid cells at this point. We typically see these only in myeloid cells. But we are doing more single cell. We have more single cell experiments planning on the study to evaluate the different subsets, what's mutation profile in the different subsets in more mice. And we also have a lot of single cell RNA sequencing data we've collected that we're starting to analyze to understand more about what's going on, what's happening with the transcriptional profiles at the different stages of hematopoietic development. Especially in the MX1 Cree mice, where this is expressed at the early stages of hematopoietic development. So we haven't seen it in in the few cases where we looked at B lymphocytes, but we have a lot more mice and a lot more to look at single cell DNA sequencing of the different cell subsets. So that's something we're still. It looks like negative for now, but we have a lot more data we have to collect before I can definitively answer that question. So
I think Jean-Francois has a question.
HAF.
Thank you. Hi. Thank you for this great presentation. I have two questions. I'm quite surprised by the platelet level, which is downregulated. Do you have any sign of macrophage activation syndrome? And my second question is about the neurology. Do you have any sign of neurological involvement in your mice?
We haven't seen it. We don't see any signs of macrophage activation syndrome right now. We could do more functional studies on the macrophages in the mice, but we don't. There's no evidence. There's no classic histological evidence of the engulfment and destruction of lymphocytes that you typically see in macrophage activation syndrome. And we had the
brain.
Brain CNS. We haven't seen CNS. Haven't seen CNS involvement. The mice so far we haven't. We do see the brains. We don't see a lot of histological involvement of the brain in the few we've studied, but the mice definitely don't develop any kind of neurological involvement. Unlike the CSF1R Cree models that Geisman lab that we worked on with the Geisman lab with BRAF V600 did in the past. We don't have a lot of CNS involvement or the neurological symptoms in these mice that we have seen under CSF1R Cree and BRAF V600. So far we have not, and nothing in some of the brains we looked at, but we'll still need to look at that more carefully as we study these mouse models and more in depth.
I think there's a question from Kim Nichols actually. Before I ask, have you looked at serum cytokines, interferon gamma, others?
We haven't looked at serum cytokines yet. That's something I will be doing on these mice. Now we got more of a phenotype to something we want to look at serum cytokines and look at cytokine level. We have not done that yet, but that's something we do have planned.
Okay, I have a sort of a question and observation. You know, I noticed that both the cases that you had resistance to MEK inhibitor were ECD, am I right? Or do you have LCH cases that did not respond to MEK inhibitor as well? With
I'll
this,
answer.
I'll let Eli answer about the cohort. So
We've had instances of both. We've had more instances of LCH responding to MEK inhibition. So of those refractory, probably more have been EC, but we have had LCH patients, pure LCH with this mutation who have been resistant.
okay, yeah, that's what I was reflecting, because I have a patient currently who is in a remission with trametinib with the same in-frame deletion, and there are 2 published cases, of course, as you may be aware of, with the same in-frame deletion in histiocytoses in LCH, and also I think in other solid tumors that have responded. Of course, preclinical models have suggested that this may not respond. So I was just curious if there is any, any reason you would assume like is there something other predictive where you can say in your preclinical model that, this would lead to response to MEK inhibitor versus not?
Well, I can answer some of the biochemical work that came out of Noah Rosen's laboratory looking at the class 3 MEK1 mutants. They're involving the area of the serine threonine kinase domain of MEK1 that actually involves a previously unappreciated autoregulatory domain to help. So this could be causing disruption. Their prediction is disruption of this autoregulatory domain, where the class 3 MEK1 mutants tend to occur, these in-frame deletions, which would lead to, of course, constitutive activation without a loss of a check and balance on activated MEK1. So on the kinase domain. So that's one of the biochemical theories that's come out of Neil Rosen's work when he looked at this in solid tumor cell lines and melanoma. But in the mouse models, we haven't found anything, but that's something that's definitely looking at these mutations, which have never technically been crystallized, and MEK1 looking at actual structure is something that's going to be very interesting in both the mouse protein as well as protein purified from human as well, to understand more about the structure and the involvement of this class 3 MEK1 mutations in that part of the MEK1 protein.
Okay.
Is there a question from Sheila or comment?
Yeah, Dr. Weitzman.
Yeah, this is Julian. Very nice talk, Ben. I just to I don't know if it's maybe more for Eli. I saw that there was some a case that was followed by Abdelatif. I'm not aware of the patient who had mixed LCH and ECD with the same MAP2K1 mutation, and who progressed under trametinib and who was after responsive to cobimetinib as a salvage therapy. So do you see sometimes some differences between the responses from either trametinib or cobimetinib, or do you have the same resistance when you have this kind of mutation?
In our patients who are resistant, I tried both.
Okay.
Sometimes even binimetinib as well. Ben, one question from Kim. Can you remind us the frequency of this variant among the MEK mutants?
This is the most frequent MEK1 mutation in our cohort. The frequency, I'd say, I'd look at the frequency number, but it's the most frequent MEK1 mutant out of all of our MAP2K1 mutations. It's more common in LCH than in non-LCH neoplasms, but I've seen it in both. And particularly we see this. So I'd say it's definitely close. It's close to, I think, about 40. It's close to about 40% of, I think, of the mutations. I'd have to double check the number, but I think it's close to 40% of the mutations. But it's the most frequent MEK1 mutation, single MEK1 mutation, basically, compared to in our cohort, compared to all the others. So.
Okay, that brings us to the top of the hour. Thank you, everyone, for attending. Thanks to Dr. Durham and Dr. Eskaya, and to the panel, and we will see you on the next one. Take care and be well.